Hello everyone. Hello everyone. I am Dr. Bipul. Welcome to my channel. Today we will be discussing something on age-related macular degeneration. According to the definition, it's a common chronic progressive degenerative disorder of the macula that affects the older individuals and features loss of central vision as a result of abnormalities in the photoreceptor, retinal pigmentary epithelium, Brooks membrane, choroidal complex, often resulting in a geographic atrophy and or neovascularization. Now coming to the epidemiology, the World Health Organization estimated in 2002 that 8.7% of the world's blindness was due to AMD, with 14 million people worldwide being blind or severely visually impaired because of it. The disease nearly always begins as a non-invasive neovascular or dry form and may progress to geographic atrophy or neovascular form in one or both eyes. Patient can have advanced dry AMD in both eyes, advanced wet AMD in both eyes, or dry form in one eye and wet form in the fellow eye. It is controversial whether wet or dry forms of AMD represent two distinct entities or these are end-stage manifestation of the same disease. In general, advanced AMD is rare before the age of 55 years and more common in persons 75 years of age or older. The prevalence of advanced AMD increases with each decade after the age of 50 years, with the highest prevalence occurring after the age of 80 years. AMD in one eye have a 50% chance of developing advanced AMD in the fellow eye within 5 years. Now coming to the pathogenesis. In the early process, what happens is lipids are deposited in the Brooks membrane, possibly from the failure of the RP to process the cellular debris associated with outer segment turnover. The appearance of the drusen is preceded by or concomitant with the thickening of the Brooks membrane, degeneration of elastin and collagen fibers in the Brooks membrane with calcification of the Brooks membrane. There is increased levels of advanced glycation end products, accumulation of lipids, as well as exogenous proteins, amyloid, complement factors, and additional cellular components underneath the RPE. This forms a hydrophobic barrier to impede the passage of fluid and nutrition between the choroid and the retina, resulting in relative ischemia with subsequent ingrowth of neovascularization from the choriocapillaries through the fractures in the Brooks membrane. Now coming to the family history, it has been established and it is a determinant risk factor shown from various twin studies. It is now accepted that dysregulation of innate complement pathway leads to aberrant inflammatory responses resulting in accumulation of debris within the Brooks membrane. The importance of heredity was confirmed when polymorphism within genes encoding complement factor H, HTRA1, complement C2, CFB and C3 were shown to be predictors of risk of AMD. The most important environmental factors are smoking and obesity. Other factors are atherosclerosis, oxidative damage, phototoxicity, diet, and chronic inflammation. Now, coming to ocular manifestations. The dry age-related macular degeneration is clinically typical. Drusens appear as whitish yellow excrescences deep in the retina. Generally, they cluster in the posterior pole, but this can occur anywhere in the fundus. The drusen in an extramacular region are of no known visual consequence. Typical drusen deposits are located between the RP and the Brooks membrane and vary widely in the number, size, and shape and distribution. This can be small, intermediate, and large according to the size. The small of less than 63 microns in diameter, intermediate more than 63 to less than 125 microns in diameter, or large greater than equal to 125 microns diameter. The hard drusen's appear as round, discrete white-yellow spots measuring less than 63 microns, commonly identified in many populations. These do not carry the risk of development of neovascularization, and approximately 80% of the general population of more than 30 years manifest at least one of this lesion. The soft drusens are ill-defined, with non-discrete borders measuring 63 microns in diameter or greater. These have higher risk of development of advanced form of AMD with neovascularization. After the age of 70 years, around 26% have larger or soft drusen and 17% have confluent drusens. Now these are two pictures where you can see first picture is a color fundus photograph showing soft drusens which are having non-discrete borders which are of larger size coalesce with each other, and the left side sorry on the right side you can see a color fundus photograph of hard drusens which are smaller in size with discrete borders. Now there is another entity called as reticular drusen or reticular pseudodrusen which appear as yellow-white faint interlacing network. These are changes in the choroid with loss of choroidal vessels accompanied by fibrous replacement of the choroidal stroma in a reticular pattern. These are shown to be associated with high risk of progression to neovascular AMD with development of atrophic AMD. Drusens alone do not cause severe visual acuity loss but can be associated with complaints like light adaptation, mild metamorphopsia, loss of reading speed, and impaired contrast sensitivity. The focal hyperpigmentation of the RP is another uh, important clinical feature of non-neovascular AMD. These have increased risk of development of soft drusen and geographic atrophy increases in its presence. Now these are some pictures of reticular pseudodrusens. First is a color fundus photograph where you can see yellow-white network of lesions surrounding the fovea. The second one is a infrared picture where you can see reflectance image hyperreflective areas dispersed throughout the perifoveal region surrounded by boundaries of mild hyperreflective coalescence forming a net-like appearance. The third image is a fundus autofluorescence where you can see widespread hypofluorescence lesions surrounded by boundaries of mild hyperfluorescent autofluorescence which is there. And the last image in the downward part is a spectral domain OCT where you can see white triangles. These are lesions. These are reticular pseudodrusens which are hyperreflective lesions which can be seen between the ellipsoid layer and the RPE layer in contrast to the typical drusens which you can see with the red triangles underneath which are underneath the RPE, not between the ellipsoid layer and the RPE. According to the International Age-Related Macular Epidemiological Study Group, the AMD can be graded into 4 grades, grade 1, 2, 3, 4. The grade 1 is graded as no AMD, where there are no drusens or only a few 5 to 15 small drusens in the absence of any other stage of AMD. The grade 2 is early stage of AMD, where you can see extensive small drusens of more than 15 or a few medium-sized drusens of less than 20, or there could be pigment abnormalities like hyperpigmentation or depigmentation, but there is no geographic atrophy or no other stage of AMD. The grade 3 is intermediate stage of AMD, which refers to the presence of at least one large drusens, but can also be applied to the eye with numerous medium-sized drusens of more than 20. The grade 4 is the advanced stage of AMD, which is reserved for presence of geographic atrophy extending under the center of the macula or presence of neovascular AMD. Now, coming to another clinical feature, uh, the geographic atrophy, which is seen with dry AMD. This is seen as one or more well-defined areas of hypopigmentation or depigmentation due to absence or severe attenuation of the underlying RPE with large, deep choroidal vessels which are visible more readily through the atrophic patches that also lack the photoreceptors and choriocapillaries. These are areas usually small and may surround the fovea in a petaloid pattern of less than a disc area. They typically coalesce over time or manifest as a large central lesion up to 7 millimeter in diameter. The visual acuity loss in the dry form of AMD is generally due to this, that is geographic atrophy involving the foveal region. The reading vision may remain poor because of constricted central visual field, and the onset of geographic atrophy with mean duration of legal blindness is 5 to 9 years. These are pictures of geographic atrophy. First is a color fundus photograph. Second is the autofluorescent, where you can see the uh, underlying defect which is there because of loss of RP or atrophy of the RP. The third image is a fundus fluorescent angiogram early phase, where you can see bright uniform lacy pattern. Where you can see hyperfluorescence which is increasing in intensity in the late phase. The last image is of a OCT where you can see the reflectivity bright area due to increased penetration of the light into the choroid, where the atrophy of the RPE has occurred from the reflected light underneath the RPE from the choroid. Now coming to neovascular age-related macular degeneration. Neovascular age-related macular degeneration or wet AMD is characterized by the presence of neovascularization within the macula. This may result in ingrowth of neovascularization from choriocapillaries under the macular region, which is called as choroidal neovascularization, or it may arise predominantly from the retina, also called as retinal angiomatous proliferation. In the advanced form of neovascular AMD, it is not unusual to see retinal choroidal anastomosis, a communication between the retina and the choroidal circulations. The patient will often report a sudden worsening of the central vision, often with distortion. The clinical manifestation could be subretinal fluid, intraretinal fluid, retinal subretinal or sub-RP hemorrhages, lipid exudates, gray or yellow-green discoloration or plaque-like membrane, RPE detachment or RPE tear. In the end-stage disease, the neovascularization results in a fibrovascular or atrophic macular scar and subsequent permanent damage to the central vision. Now, this is a picture of choroidal neovascularization where you can see photoreceptors, the RP, the Brooks membrane and the choroid, and you can see through the breaks in the choroidal the Brooks membrane, the choroidal neovascularization is occurring underneath the RP. Now these are some pictures of wet AMD, the classical picture of wet AMD, where the first image is a color fundus photograph, the second one is the autofluorescence, where you can see some areas of autofluorescent hyper autofluorescence, which can be due to the drusen's in the superior underneath this in the perifoveal region in the superior part. The, the third image on the upper view, you can see it's a fluorescent angiogram in the early phase, and the fourth view is the late stage of the fluorescent angiogram. The early phase, you can see a bright uniform lacy pattern, and in the late stage you can see a leakage and staining obscuring the boundaries of the lesion. Now the down images on the right, the left side are the OCT images, and the right side, extreme right, is the retinal thickness map. OCT image, you can see this choroidal neovascularization with presence of subretinal fluid underneath the RP, and the retinal thickness map, there is increase in the central retinal thickness. Now another entity which can be seen in wet AMD is detachment of retinal pigmentary epithelium. The retinal pigmentary epithelium may be detached by either a serous fluid, a fibrovascular tissue, hemorrhage, or it could be due to coalescence of drusen's underneath the RP. The hemorrhagic PED manifests as dark elevation of the RP due to underlying blood, showing blocked fluorescence throughout all the phases of angiography. Serous PED appears as dome-shaped detachment of the RP, exhibiting bright, diffuse hyperfluorescence with progressive pooling in a fixed space. The drusenoid PED is caused by coalescence of the drusens. This show as staining, often with fading fluorescence in the late phase and an absence of leakage. These are two set of images. The second one is a drusenoid PED, where you can see the staining is occurring, which is decreasing in intensity, and in the OCT picture down you can see drusens, coalescence of drusens, which is leading to detachment of the RP. The first group of image is a group of image where you can see a serous PED occurring. The first image is a fundus fluorescent, the fundus photograph, color fundus photograph. Second one is a fundus fluorescent angiogram, where you can see the pooling of the dye, hyperfluorescence is there, and pooling of the dye underneath the serous collection, which is confined to a space. The third one is a fundus ICG, where you can see a window defect due to the serous collection. And the fourth and the fifth images are OCT images, where you can see the dome-shaped elevation due to collection of serous fluid underneath the RP. Now these are images which shows first one is a image of fibrovascular PED, where you can see the fundus fluorescent angiogram in the early, mid, and late phase. In the early phase, there is nothing which you can see. The mid phase, you can see this stippled fluorescence, which is increasing in intensity in the late phase. And in the OCT picture, you can see fibrovascular growth underneath the RPE, which is detaching the RPE. And the second one in the right side, you can see a color fundus photograph of a PED due to hemorrhage. Now, based on the angiographic patterns of fluorescence, the neovascular lesion may be characterized as either classic or occult. Classic CNV is characterized by bright, uniform, early hyperfluorescent or lacy pattern, which I have already demonstrated during the early phase, and these exhibit leakage in the late phase, which obscures the lesion boundaries. The classic CNV is classified topographically according to the its relationship to the center of the foveal avascular zone on fundus fluorescent angiogram as follows. Could be extrafoveal, it could be juxtafoveal or subfoveal. Extrafoveal 200 to 1500 microns from the center, juxtafoveal 1 to 200 microns from the center, and underneath the center it is subfoveal. The occult CNV is recognized angiographically by one of the two patterns. Either it could be a fibrovascular PED or it could be a late leakage from undetermined source. The fibrovascular PED I have already shown you in the previous picture. It is characterized by an area of irregular elevation of the RPE, which is neither as bright nor as discrete in classic CNV, often with stippled hyperfluorescence present in the mid phase of the angiogram and leakage or staining in the late phase. Whereas in the late leakage of undetermined source, this usually appears as speckled hyperfluorescence with staining and dye pooling in the subretinal phase in the late phase, not in the mid phase or the early phase. The source of leakage does not correspond to the classic CNV or the fibrovascular PED, which I mentioned, that doesn't occur in the early and mid phase of the angiogram. Now, signs and symptoms: early or intermediate AMD may be asymptomatic. The distorted vision in the form of metamorphopsia, in which rigid the in which a grid of straight lines appears as wavy and parts of the grid may appear as blank. There may also be central scotomas, shadows, or missing areas of vision. The patient often may first notice this when looking at things like curtain blinds in a home, or when he is driving, he may find it while looking at telephone poles or telephone wires or telephone lines. Now, apart from that, there could be slow recovery of visual function after exposure to bright light, which can be tested with photo stress tests. The visual acuity may be drastically decreasing to two levels or more. Example, from 2020 to 2080. There could be blurred vision. Those with non-exudative or dry form of macular degeneration may be asymptomatic in the first instance, or may notice gradual loss of central vision, whereas those with exudative macular degeneration often notice a rapid onset of visual loss, often caused by leakage or bleeding of abnormal blood vessels. There could be trouble discerning colors, especially dark colors from dark ones and light colors from light ones. There could be a loss of contrast sensitivity, and in the advanced form of disease, there could be formed visual hallucination and flashes of light seen in visual loss secondary to wet AMD. Now, diagnosis and ancillary testings, what we can do to find all these things, like Amsler is great to find out metamorphopsia.
Lead option charts may be
Utilized to see for uh, degradation of the contrast sensitivity. A dark optometry can detect subclinical AMD at least 3 years earlier than it is clinically evident. And autofluorescence, fundus autofluorescence, we can see areas of geographical atrophy which exhibit as low or extinguished autofluorescence signal or dark signal due to loss of RP and lipofuscin, which leads to a region with high contrast transition between the area of atrophy and the perilesional area. Various patterns of this perilesional autofluorescence changes may be predictive of the disease progression. Other modalities of investigation are OCT, which is useful to assess the ultrastructure of the drusen and to examine the adjacent retinal layers that can be compromised by the disease process. The progression to early AMD from the early AMD to severe forms such as geographic atrophy can be monitored. It can be used to identify some of the wet AMD features such as presence of intraretinal or subretinal fluid or presence of retinal PEDs, which could be classified into various forms according to the constituents like serous PED or fibrovascular PED or hemorrhagic PED or drusenoid PED. The effect of anti-VEGF therapy can be assessed based on qualitative appearance of the B scan, as well as quantitative changes in the retinal thickness map, which could be effective in resolving the macular fluid and the area or volume of the PD, thus monitoring the natural history and treatment effect. Now, fundus fluorescence is another investigation which can be done, which is useful to perform, which is usually performed to confirm the presence of neovascularization, and this identifies the characteristics of lesions, including the local location, the composition of the neovascularization, and may be helpful in serving as a baseline examination for further studies to decide whether the treatment has been effective or not. Based on angiographic patterns of fluorescence, the neovascular lesions can be characterized either as occult or classic. The angiograms are also helpful in evaluating the presence of hemorrhage or blocked fluorescence that does not correspond to hemorrhage or serous detachment of RP. ICG is an entity which can be utilized to categorize the various forms of CNV as hotspots or plaques or a combination of the two. In patients with dry AMD, it might help to identify plaques representative of asymptomatic choroidal neovascularization, which may represent areas of occult CNV or watershed zones, which may be predictive of future exudative transformation. This may help in diagnosing other choroidal conditions like IPCV, where you can see branching network of vessels in the inner choroid and vascular dilatations at the border of the network of vessels. Then ICG can be useful in diagnosing this wet AMD from centrocilious chorioretinopathy. These are some pictures of wet AMD, and first is a fundus photograph, color fundus photograph, where you can see bleeding with fluid accumulation under the macula. The other pictures are ICG pictures in the early, mid phase and late phase, where you can see dilatation of the choroidal vessels, the superior part of the macula. Then in the mid phase you can see hyperfluorescence developing in the macular region and increasing in intensity in the late phase. This is a typical hotspot appearance in ICG. Now, these are images of IPCV, idiopathic polypoidal choroidal vasculopathy, where you can see polypoidal hyperfluorescent lesions which are increasing in intensity with each phase of the angiogram. Now, coming to differential diagnosis, it should be differentiated from various hereditary disorders like pattern dystrophy, Stargardt's disease, Best disease, and angoid streaks. Uh, it should be differentiated from CSR, macular telangiectasia of type 1, multifocal choroiditis, APM, PPE, toxic lesions like toxicity due to chloroquine, phenothiazine, canthaxanthin, cuticular drusen with or without vitelliform lesion, or adult vitelliform dystrophy. Now coming to the treatment and prevention. The dry AMD, vitamin supplementation, dietary modification and cessation of smoking are the current recommendations thought to slow the progression of visual acuity loss in dry AMD. According to the ARED study, if an individual of more than 55 years is having one or more risk factors, they should be considered for oral antioxidant supplementation with vitamin C of 500 milligram, vitamin E of 400 international unit, beta carotene of 15 milligram, zinc oxide of 18 milligram, copper oxide of 2 milligram. The beneficial effects are seen in patients with high risk of developing advanced stages of AMD. This lower the risk of advanced AMD by 25% and relative risk of visual loss of 3 or more lines by 19%. Now, oral supplementation has demonstrated that there is an increased risk of lung cancer in those patients who are smokers who are taking beta carotene. So, beta carotene should be excluded from the regime of this type of patients. Now, AREDS 2 study recommends use of lutein and zeaxanthin and omega-3 fatty acids along with the other supplements which are described in AREDS 1. Treatment of neovascular AMD, the benefit is only likely in the presence of active disease, which is evidenced from increased fluid or hemorrhage underneath the macula, leakage on fluorescent angiography, choroidal neovascular enlarging choroidal neovascular membrane, or deteriorating vision judged likely to be due to choroidal neovascular activity. The presence of fibrotic disciform scar makes the treatment extremely unlikely even if there is a presence of active CNV. RP tears may be a relative contraindication to treatment. Now, the treatment modalities include conventional laser photocoagulation, which is now rarely used for retinal angiometric proliferations. Ocular PDT is another modality with vertiporfin, which can be used, and inhibitors of vascular endothelial growth factor, anti-VEGF drugs, including pagatinib sodium, bevacizumab, ranibizumab, and aflibercept. These can be used. The off-label use of bevacizumab has gained the popularity as an alternative to ranibizumab because of its worldwide availability, efficacy, safety, and low cost. What is PDT or verteporfin PDT? This is a technology which utilizes low energy light to activate the intravenously injected photosensitizing agent verteporfin and induce the closure of neovascular complex, where it is used in the concentration of 6 mg per kg body weight intravenously. Then the fundus is exposed to low energy light, laser light for 80. The injection was given for a duration of 10 minutes. There should be a gap of 5 minutes after that. Then it is exposed to low energy laser light for 83 seconds. Now, according to the TAP study, which has identified statistically significant treatment benefit for a specific subgroup of individuals by PDT, uh, uh, which is predominantly classic CNV type, and another study, VIP study, which identified a statistically significant benefit with 54% of the patients in this PDT group experiencing moderate visual loss as compared to 67% in the placebo group. Now, even though PDT has replaced the conventional laser photocoagulation for treatment of predominantly classic subfoveal CNV due to AMD, most patients experience continuous visual loss even after the treatment. Now, with preliminary results suggesting PDT along with corticosteroids or ranibizumab reduce the need of retreatment and yields visual acuity outcomes better than PDT alone. But these results are overshadowed by the visual acuity and anatomical benefits observed from monotherapy with use of anti-VEGFs. Anti-VEGF therapy are the only therapy which is being utilized by widespread for the treatment of wet AMD, and this is due to the consistent correlation between the pathogenic neovascularization in the eye and expression of VEGF-A, providing a strong evidence to suggest that inhibition of this VEGF-A in the eye could be a viable treatment strategy for this type of exudative ocular diseases. So pagatinib sodium was the first anti-VEGF which was approved by FDA in 2004 for the treatment of neovascular AMD after vision trials. Now, vision trials, the patients with neovascular AMD were randomized to receive intravitreal injections of pagatinib sodium in various concentrations of 0.3, 1, and 3 milligram vis-a-vis sham injection at 6 weeks intervals for 48 weeks, and at 1 year the zero point 0.3 milligram dose of paclitaxel sodium was superior, found to be superior to sham injections, and appear to be more effective than 1 milligram and 3 milligram doses. The 2-year study demonstrated that patients treated with zero point 0.3 milligram of paclitaxel sodium for 2 years were more likely to maintain a visual acuity compared with patients who received usual care for 2 years or who have stopped the treatment of paclitaxel sodium after 1 year. Ranibizumab is another monoclonal antibody and antigen binding fragment that binds and inhibits all aforementioned biological active forms of VEGF-A. This is administered as an intravitreal injection, and this has received the FDA approval in 2006 on the basis of two pivotal studies, phase 3 trials. These are Marina and Anchor trials. According to the Marina trial, it was a randomized double-mask sham-controlled 2-year study of monthly injections of intravitreal ranibizumab of zero point 0.3 and zero point 0.5 milligram in minimally classic or occult CNV secondary to AMD. Not only did ranibizumab treatment prevented the visual loss, but it was also the first neovascular AMD trial to show average visual acuity improvement after 1 year. A treatment benefit was observed with ranibizumab treated group compared to sham group, regardless of the patient's gender, age, type of the lesion, the size of the lesion, duration of disease, with improvements in both the angiographic and the OCT outcomes. In an attempt to decrease the burden of monthly injection, alternative dosage strategies were pursued through another study, that is PRO-ONTO study, which utilized OCT imaging dependent individual dosing strategy. So OCT guided retreatment strategy appeared to result in similar visual outcomes with very fewer intravitreal injections. Anchor study was another multi-center randomized double-masked 2-year study which compared monthly intravitreal ranibizumab with vortiporfin PDT patients with predominantly classic CNV secondary to AMD, and this showed at 2 years that 90% to 89%, 90% and 89% of treated patients with ranibizumab zero point 0.3 and zero point 0.5 milligram respectively avoided a 15 letter loss compared to 65.7% with the PDT control group with a P of 0.001, and visual acuity improvements of at least 15 letters were observed in 34.3% and 41% of treated patients with ranibizumab zero point 0.3 and zero point 0.5 milligrams respectively, as compared to 6.3% of the PDT control group with a P of less than 0.001. Now, various retrospective and prospective studies have been reported significant improvement in the mean visual acuity and reduced OCT central retinal thickness in patients with neovascular AMD following monthly or OCT guided intravitreal bevacizumab at doses ranging from 1.25 to 2.5, and to better the assess of bevacizumab's safety and efficacy and to compare it with ranibizumab, National Eye Institute has sponsored the CAT study, and at the year 2 of this study, the proportion of patients who avoided at least a 15 letter loss of vision ranged from 88.4% in bevacizumab group as needed group to 93.3% in the ranibizumab monthly group, although there was no significant difference in the mean visual acuity between the drugs. For both the drugs, the visual outcomes at 2 years were similar between the groups when that switched from monthly to as needed treatment and those treated with as needed regime for 2 years. And one of the interesting observation from CAT trial is that that may be important in the guiding of the drug and regime decision was the proportion of eyes with new onset geographic atrophy at 2 years. It was seen that the geographic atrophy occurs greater among patients treated on monthly regime as compared to the as needed regime. Aflibercept is another fusion protein containing VEGF receptor ligand binding domains and the FC region of IgG1, which is studied as a intravitreal drug under the CLEAR IT2 study. A phase 2 study which used this drug intravitreally showed a decrease in the central retinal thickness and increase in the visual acuity in all treated groups after 12 weeks of fixed dose injection, either quarterly or monthly, followed by as needed dosing. The phase 3 studies of this agent with view 1 and view 2 were compared, where the concentration of drug of 0.5 to 2 mg given monthly for 3 consecutive months, followed by same doses every 4 weeks or 2 milligram every 8 weeks compared with ranibizumab every 4 weeks. So this drug was compared with ranibizumab and patients were followed for 1 year. View 1 was conducted in USA and Canada. This showed that 95 to 96% of the patients treated with aflibercept maintains a visual acuity compared to 94% in the ranibizumab group. And the View 2 trial, which was conducted in Europe, the Pacific, Asia Pacific, Japan, and Latin America, the same type of results, like 96% of patients with aflibercept group achieved a maintenance vision compared to 94% in the ranibizumab group. But there was no statistically significant difference between the mean change in visual acuity in all groups of vision view 2, whereas there was significant improvement in vision which was seen with aflibercept as compared to ranibizumab in view 1 study. Now those who have untreatable visual acuity loss, they should be given low vision aids like reading lamps, like magnifying glasses and closer circuit televisions uh, to perform normal activities. Now coming to the conclusion, vitamin supplementation, dietary modification and smoking cessation appear to be the most useful strategies to to slow the progression of dry AMD, and with the result of CAT showing monthly dosing with anti-VEGF agents which increases the incidence of geographic atrophy, it seems reasonable to avoid monthly dosing and provide personalized treatment strategies using either the as needed or treat and extend regimes in wet AMD.